Hey there, Empowered Tribe. It's Angela T. Moore. You're getting ready to experience the 11th episode of Empowered, a health and wellness podcast where I share my personal journey of health and healing, tips for mental and physical health, interviews with health and wellness experts and those bold enough and vulnerable enough to share their own journeys to empower you to succeed in yours. We know that life can be rewarding. It can also be challenging. It has its ups and downs, highs and lows. I learned that with a strong mind and a fit body, you are better able to grow through and grow from whatever life throws your way. My goal is to share journeys of health and wellness, as well as tips and information from extraordinary people all around the world to help you live an empowered life. My guest, Dr. Thomas O'Neill, was named Director of Medical Affairs for the NorthStar Care Community in March 2023. In this role, Dr. O'Neill manages members of the not-for-profit's medical affairs team, including all physicians and nurse practitioners at Hospice of Michigan, Arbor Hospice, and NorthStar Palliative Care. Dr. O'Neill serves as Director of NorthStar Palliative Care and as the hospice physician for the Hospice of Michigan Detroit Dearborn team, serving and caring for patients in Wayne County. NorthStar Community preserves and promotes the mission of not-for-profit hospice and palliative care, delivering expert, compassionate care to patients of any age, no matter their diagnosis, complexity of care, place of residence, or financial circumstances. In this episode, Dr. O'Neill and I talk about palliative care. Palliative care has been shown to prolong life and improve prognosis in patients with certain conditions. And if implemented early, palliative care not only improves quality of life for patients, but also reduces unnecessary hospitalizations and use of healthcare services. Palliative care is an additional layer of support for people of all ages, especially those 65 and older, living with serious or terminal disease. Dr. O'Neill talks passionately about the work and the mission to deliver compassionate care. I hope you enjoy the episode. Dr. O'Neill, in November, NorthStar Care Community was awarded a $350,000 grant from the Michigan Health Endowment Fund, which is intended to support the NorthStar Palliative Care program expansion throughout the city of Detroit. Can you tell me more about the grant from the Michigan Health Endowment Fund and how the grant will support the expansion throughout the city of Detroit?
Absolutely. So we were very lucky to be one of the recipients of the Michigan Health Endowment Fund's grants for the next 2 years. And the goal and purpose of our grant was to expand palliative care services into the city of Detroit itself. And so the Michigan Health Endowment Fund, it exists to promote the health and well-being of all Michigan residents. And there was a number of other grant recipients, but for us, our purpose with the grant and our application for the grant was to expand the palliative care services into the city of Detroit. So we're very lucky that we got chosen. We're very honored, and we're very excited to kind of start to do palliative care for people that live in the city of Detroit.
Yeah, very interesting. I was really excited when I saw that I was going to have the opportunity to interview, because I don't think a lot of people know much about palliative care. I think a lot of people know more about hospice care,
Sure.
And which we'll get into the specifics of those two terms, because I know it's a significant difference. But one of the things that I did want to ask you is that I learned in my research that Detroit is designated as a medically underserved area. And for those that may not be familiar with that phrase, what does it mean when you say that Detroit is designated as a medically underserved area?
Yeah, the state of Michigan, as well as the federal government, have definitions for medically underserved. Sometimes those definitions involve access to healthcare services, and sometimes they involve, the amount of providers that exist within a certain population or exist within a certain geographical area. The city of Detroit, unfortunately, meets both of those things. And so that was one of the key components of our grant is, the citizens of Detroit, they typically have limited access to all medical services, palliative care certainly being one of them. And that was what we wanted to do, is we wanted to expand access to palliative care services within the city.
Gotcha. Now, NorthStar Care Community, abbreviated as NSCC, preserves and promotes the mission of not-for-profit hospice and palliative care, delivering expert, compassionate care to patients of any age, no matter their diagnosis, complexity of care, place of residence, or financial circumstances, which is really important. How does NorthStar Palliative Care plan to address the limited access to home-based palliative care services for patients with chronic and terminal illnesses?
Excellent. I think that's a great question. So one of the things that you find as you start to look at palliative care is that different people define palliative care differently. Mm-hmm. The scope of their services, what those services look like, and even where those services take place. So when we were designing a palliative care service for patients and families, one of the things that we were very intentional about was we wanted to take transportation and transportation barriers out of the equation. It's hard when you have a chronic or terminal illness to get to the doctor. It's hard to find transportation, hard to find reliable transportation, even harder, like it is now here in Michigan in January when there's weather and other considerations too. So we said, look, let's take that one barrier at least off the patient and family. We'll go to your home. So our nurse practitioners, when they're going for the palliative care initial assessment and for follow-up assessments, we are happy to go ahead and we drive to the patient's home, we do our assessment in the home, and we're always available through telehealth and through the phone as well. So we don't have a physical clinic. We go to people's homes so that they get the care in the home.
Okay. Now, I don't know that I understood that, and I think that's really amazing. It's interesting because as a therapist, oftentimes clients would come to me. They come to my office, and I see them. During the pandemic, what was really interesting is I got to see a lot of clients in their homes because we would do like virtual sessions. And it was amazing because as the client presented themselves in the office, they're very different than how they presented themselves, say, virtually. And what I mean by that, there were a couple times when I was actually meeting with the client, and because I could see their home environment, I saw their living condition, and this is virtually, okay? I also saw when I was talking with a client, some of the interactions they would have with other family members that I would have not normally observed in an actual in-person session, which was really interesting. You mentioned that now your company actually goes into the homes of individuals. I imagine that allows you to see and benefit from observing their interactions with their family members, to see their home environment much more than what I was able to experience in a virtual session.
Absolutely. And it can be, things like safety and falls, and where do they set up the oxygen, and where's the tubing, and do they have a commode, and how are they getting around, to even very practical things like show me your medications. Gotcha. How are you giving these medications? Or, if you have the patient's bedbound, maybe somebody comes in the morning, somebody comes at night. How are they talking to each other? And starting to look at some of those systems that really can have a big effect in terms of outcomes, symptom control, disease management, so on and so forth, that are typically lost when patients come to a clinic appointment. So we get a chance to kind of put our eyes on those things and how are you actually being cared for moment to moment in the setting that you're being cared for.
Gotcha. Now, typically, are they seen by the same medical professionals?
We prefer to do that. I think patients and families appreciate the continuity. I think that the first visit for palliative care can be somewhat long. It's usually about an hour or so. And I think patients and families really start to get comfortable with their nurse practitioner. And so when possible, we like to honor that and keep them going with the same nurse practitioner as well. And I would say that's for palliative care. And the other thing that we really encourage too is that when patients change from palliative care to hospice services, they can keep the same provider as well to continue to provide some of that continuity in their care.
Okay, that's really important. Yeah, because I imagine when you're in a difficult time of your life, when you're experiencing a significant illness, a disease that you have dealt with for quite some time, to be able to have, like you said, the continuity of care provided by the same person, especially as your condition progresses in the negative, unfortunately, towards the end of your life, I imagine it would really mean a lot to have someone that you're comfortable with, that you have an established relationship with, that knows what your progression has been.
Yeah, that they, and that's the goal, is that they get to know our providers, they trust our providers. Our providers hopefully have helped them deal with some very distressing symptoms. They've hopefully helped them consider what their medical decisions are, what their options are for care, how to best engage with those options. And so some of those options may be very straightforward, but when it comes to more difficult decisions, more complicated decisions, more emotional decisions, they also have somebody that they know and trust that can help them with those too.
Yeah. Now, you kind of alluded to this. You mentioned hospice, and I understand that both palliative care and hospice care specialize in managing symptoms and facilitating goals of care conversations for those with life-limiting diseases and illnesses. While similar in many ways, there are distinct differences in the treatment and the care that patients receive. So can you explain the difference between the two? What is palliative care, and how does it differ from traditional hospice care?
I think that's a great question, primarily because there is so much confusion around what is hospice, what is palliative care. And as I said earlier, part of that problem comes from the fact that different companies do palliative care differently. And so even in the marketplace, one palliative care service or one palliative care clinic may look different than another. But speaking in broad strokes, hospice is for people who have a terminal diagnosis and they have a prognosis of 6 months or less if the disease runs its expected course, and they want to focus on comfort. They want to be at home. They want the care that comes to them. And so hospice is designed to do that. Hospice is paid for under Medicare, Medicaid, and all other insurance. All other insurances have a hospice benefit. And to be frank, we're a not-for-profit hospice. Even if somebody has no access to any of those, we also have a charity fund. No one should ever go without hospice care.
Okay.
So palliative care is different from hospice in that you don't have to have 6 months or less to have palliative care.
Okay.
You have to have a chronic or terminal illness, but even folks with heart disease, they have a terminal illness, but they're not in that 6 month window.
Okay.
They still struggle with symptoms of fatigue, of shortness of breath. You may have somebody with cancer that has a prognosis of 6 months or less, but they're still getting treatment. Palliative care would be very reasonable for those folks too. So what I tell people with palliative care is that it is an extra layer of support on top of the support they already have. Their primary care physician, their oncologist, the emergency room, the current tests and treatments that they're getting. Palliative care is another support for people. And the focus of palliative care is on expert pain and symptom management, as well as clarifying goals of care. And that can be an amorphous term. So what I mean by that is having conversations about what do you understand about your illness? What have the doctors told you so far?
Gotcha.
What are you expecting in the next few weeks to months to years? What are you hoping for? What are you most worried about? And how can we help you, manage some of those hopes and worries and symptoms as you're still getting treatment for your disease? Eventually, for a lot of people, they come to the point where they transition into that 6 month window. Now hospice is a much more appropriate, more robust level of care, and we transition them to hospice services when they're ready.
Okay. Now a very interesting question. I had a friend who's a family member of theirs was put into hospice, okay? So they were receiving hospice care. But they started doing really well.
Yeah.
Yeah, and they were doing well for many months. So what happens in that situation? And say if you're receiving hospice care and all of a sudden you're not, it's not 6 months until your demise. It's actually, you don't know because you're doing so well.
Sure, and that's a great question. I would say that those are some of the most fun patients to have on hospice, to be honest.
Yeah.
So I think oftentimes what happens is, for a lot of people, less is more. And sometimes when people come to hospice, we say, look, we don't really need to manage your blood pressure as aggressively. You don't need to worry about your cholesterol.
Gotcha.
And people forget that those medicines also come with side effects. And so we sometimes will back off on some of these medicines and people start to perk up. They feel better. Or sometimes people enter hospice on a dip. They've just had a heart attack in the hospital. They're not looking good. It's unclear if they're going to make it or not. They say, look, I'm ready to leave the hospital. I understand I might pass away, but I want to be surrounded at home, surrounded by my family and comfortable.
Gotcha.
Well, then they enter hospice, but all of a sudden they're getting their symptoms met. They're starting to eat a couple of meals a day and they're feeling better.
Gotcha.
So what Medicare, who dictates the hospice benefit, they say, look, every so often you need to still certify that this person has a prognosis of 6 months or less. There are some people that do better than expected, and we think that that's great. But then there are some people that continue their decline. So we're always monitoring, is hospice the right level of care, and do you qualify? And for those patients, they may have worked themselves up. They've gained some weight. Their functional status is improving. They're starting to feel better. All of a sudden, they might not be eligible for hospice anymore. And then we transition them back to their primary care physician and back to the typical medical care that they had before.
Okay, gotcha.
I think what's important for people to also know about hospice care is that patients can disenroll at any time for any reason. And so whether it's they would like a second opinion, whether it's they feel like they want a different level of care, or I tell people if they all of a sudden come up with a cure for cancer, I'll put you in the ambulance myself and send you back to the hospital.
Right.
So suffice it to say, hospice doesn't have to be a one-way street for folks. To be clear, it usually is, but not always.
Right.
And so in those circumstances, those are some of the things that we look for.
Gotcha. Now, what specific services are provided by NorthStar Palliative Care to patients?
Oh, great. So for NorthStar Palliative Care, so keep in mind that for those palliative care patients, these are people that have a terminal illness, but their prognosis is probably on the order of 2 to 3 years or less.
Okay.
And so what we do is the initial visit, we send out a nurse practitioner. Prior to that visit, we usually obtain the medical records, try and see where patients are at, what their most recent test results are, so forth. And in that first visit, the nurse practitioner spends some time asking the patients about what's most distressing about their care. Are there any symptoms that they're currently struggling that we can kind of help them with? And then starting to look at what is your support system? Who's helping you out? Yeah. How are you coping with things? It is really hard to go through cancer. It's hard to watch a loved one go through cancer. How is everyone coping with that? Who else is involved? And trying to think, are there any other social supports, whether it's Meals on Wheels, Area Agency on Aging, other resources we can get these people plugged into too to meet those needs while we're looking at helping direct the medical care and managing some of the symptoms.
Now, you mentioned Agency on Aging, correct, as well as Meals on Wheels. How important are those partnerships?
Oh, they're critical. I think when you look at a lot of healthcare outcomes, especially in medically underserved areas, there's a lot of social determinants of health. One of the things that my nurses are probably sick of hearing me say is that there are a lot of things I don't have a pill for.
Yeah.
And, whether it's quality transportation, whether it's access to food, whether it's access to faith-based resources to talk about hope and meaning and purpose, I don't have pills for those things. And so community partnerships for these patients are critical. And so one of the benefits of the Michigan Health Endowment Fund grant is that we've funded a social worker for our Detroit patients as well to help them access those community resources too.
Gotcha, yeah. That's one of the things that was so interesting. For 5 years, I did a radio show and I interviewed a number of organizations throughout that time. I wanted to make sure that I highlighted the nonprofits and the organizations that were within the communities that provided supportive services that people didn't know about. Because what I found is there were a lot of organizations that have been there for years that provided supportive services, and the people that actually lived in the community, sometimes like down the road, they were unaware that those services were available. So I could see why having a designated social worker that's going to provide access to that list of those services so you can take advantage of that would be very beneficial.
Absolutely. And we talk about different types of pain. There's physical pain and emotional pain and spiritual pain. There is administrative pain.
Yeah.
And
I can see that.
to even just to kind of call and figure out what are the resources in the community on top of all the other things that people are worrying about when they've got to see this doctor and that doctor and pick up this prescription, it's a lot. And so to have someone like a social worker that can help them and say, oh, we see that, you're having trouble kind of getting 3-4 meals, getting 3 meals a day. Let's get you plugged into Meals on Wheels. Get you plugged into some of these other services that are already here and doing great work.
Yeah. And they typically have been doing it for quite some time and very successfully.
Very much so.
Yeah. Now, I'm an advocate of a holistic approach, whether it is in sickness or wellness. I learned in NorthStar Palliative, I don't know why I keep messing up. NorthStar Palliative Care takes a holistic approach to providing and coordinating care, and a lot of that we've been talking about, and I think doing so really well. Can you talk about that holistic approach? How does it improve the quality of life for the patient?
I think that when you start to talk about a holistic approach, it generally involves starting to toe into areas that traditionally physicians don't toe into. So, if people are specialists, they're generally very disease focused. How can we fix your heart? How can we cure your cancer? And I think that is fantastic. And my colleagues in those fields really do amazing work for patients and families. But what sometimes gets lost in the focus on the cancer or the focus on the disease or the focus on, what's this lab value today or what's your blood sugar today is, how are you coping with this? What is this meaning to you now that you have a diagnosis of diabetes? How have you been doing with your wife in the hospital, every other week to get their chemotherapy? And starting to also talk to them about their values. What's most important now? For these patients with palliative care, they have a life-limiting illness. It might not be 6 months that the hospice window is, but they're dealing with some significant disease. What are you hoping for now? What are you most worried about?
Yeah.
And then trying to come up with a care plan that's consistent with those kind of hopes and worries and dreams and perspectives and beliefs, and come up with a care plan that they're really happy with. And so I would say that's kind of the way that we incorporate a holistic approach, because we talk about that. We talk about their support systems. What communities are you a part of? Who do you turn to when you need some help? Those types of things.
Yeah. I imagine that's really, really important, because I could see how when you have received a terminal diagnosis, a terminal disease, that you could easily lose hope. And because you've lost hope, then you stop taking care of yourself. You stop perhaps nurturing the relationships of the people that are important to you. And I could see how not having those, maintaining those support systems, of not taking care of yourself, of losing hope, could actually make your illness worse.
Absolutely.
Yeah.
And, studies are very clear that, when people have emotional stress, their physical stress and the way that they perceive pain is far worse. And so certainly we're going to help people that, that have pain related to their terminal illness. We're going to treat that aggressively. But we also know that if you're depressed, if you're anxious, if you are feeling hopeless, that's going to affect how your pain is perceived too. And we need to help with those as well. So that's what we like to do.
Gotcha. So in situations like that, like let's say that there's a medical provider that is assisting someone in their home, and they notice that they're perhaps dealing with depression, and perhaps they're not taking care of themselves. I know that you mentioned that the social worker would connect them with Meals on Wheels for meals.
Sure.
But would that palliative care also include, say, the social worker then maybe arranging for the person to receive mental health services, counseling, things like that, to address those issues?
Absolutely. And, whether that's getting in touch with community mental health resources, or whether it's helping somebody reestablish connections with their faith and a church community, or getting them back into whether it's like a support group for their specific diagnosis. All the way up until, our nurse practitioners are very comfortable helping people and prescribe medicines for depression and anxiety, realizing that that's part of the treatment plan, but certainly not all of it. And so that is kind of how we approach those things, but really leaning into them and just not asking, hey, how's it going? But more, how are you doing with this? How has this affected your relationships? What's been the hardest part about having cancer or going through treatments? And then hear what they have to say.
Now, I imagine that over time. Now, let me ask you this. So the services that NorthStar Palliative Care provides, how long have you guys been providing these services? I know we're talking about the fact that you're expanding your services throughout Detroit. Have you been providing care prior to that?
Yeah, that's a great question. Yeah. We've been doing it for a while. As I kind of alluded to, palliative care has mean different things to different people. And in some way, shape, or form, Hospice of Michigan has had a palliative care program for well over 10, 15 years.
Gotcha.
This kind of iteration of palliative care and this service line we've been doing for about 5, 6 years now. And we've shown in other parts of the state and even other underserved parts of the state that getting palliative care services in there really does help patients in their communities.
Gotcha. Okay. Yeah, I thought that was a very important question to ask.
Yeah. No, it's not our first rodeo.
Yeah. Well, and the reason why I was asking that question, because you did mention that, of course, these services are being provided in someone's home, and you talked about the importance of for the continuity of care and having the same people provide that care.
Yes.
I imagine that if the same individuals are going into the homes of patients, that there's an awareness, I would say, that you develop over time if you are, say, a person who's worked with a number of cancer patients, if you've worked with a number of patients with dementia, things like that. And the reason why I bring that up is because if you are a medical professional and you are very familiar with cancer, you very well will know what are the type questions that a cancer patient may have, and be able to answer those questions in an effective way.
Absolutely. And I think that, I'm very lucky to work with some very talented nurse practitioners and registered nurses in the palliative care program who are very attuned to what is the disease the patient has and what are the expectations for that disease going forward.
Gotcha.
And so for instance, for people with heart disease, kidney problems can be a big issue. Have they talked about dialysis? Oh, well, my heart is sick. Well, you need to talk about dialysis too. Or for people with dementia, falling is a normal part of that disease process.
Really? Okay.
What are you going to do for mom or dad in the home to try and keep them safe from those falls? They might not be falling yet, but what happens when they do? When do we start to look at, taking away the car keys? Kind of planning for the next steps in how we know that disease is going to unfold for folks.
Gotcha. Now, where can listeners learn more about NorthStar Palliative Care?
Excellent. You can go to northstarpalliativecare.org.
Can't get any more simple than that, right?
What's there? And it's got all the information. You can even, it's got our 800 number there, and you can even, if you know of a family member, or if you're a clinician and you know of a patient that could benefit from palliative care services, you can even make a referral online.
Gotcha. Any final words?
No, thank you for having me on the show. I think that I'm very excited for palliative care in the city of Detroit. I think that we're really going to make a difference in terms of providing patients and families with a level of support that they don't currently have access to.
Gotcha.
That we can go into their homes, eliminate the transportation barrier, help them with distressing symptoms, and then help them plan to get the care that they want. Yeah. And I think that I'm very excited for what the future holds there.
Yeah. What do you hope for?
What do you mean? That's a good question.
Yeah, what do you hope to see as it relates to palliative care? What are your hopes?
What I hope to see, especially in the next year or two, is I hope, much like you said, I hope to cultivate those relationships with the other nonprofit community organizations that are already doing good work, to make it even easier for patients and families to access those services in addition to our services, but to really become part of the medical community within the city of Detroit. That's what I'm looking forward to.
I love that. Well, thank you so much for taking time out of your very busy morning to spend it with me. I really appreciate it.
Thank you for having me.
Yeah, it's my joy and pleasure.
Thanks.
Thanks for listening to Empower It with Angela T. Moore. Feel free to share this episode with someone you think would enjoy it. New episodes come out weekly. Follow our show on Apple, Spotify, YouTube, or wherever you're listening right now.